Hi, welcome to Bone and Soft Tissue Neoplasms at bstneoplasms.com. This is the 48th case of surface growth. 25-year-old had pain in the right ankle region. This was the x-ray that was put up. These are the 5 MRI images, and they're all self-explanatory sequences. That was the histopath. And these were the choices that I had put up, and you had to decide which one. So a good number of you voted, and this is how you all voted. And let me come back to what the diagnosis is. So on the radiograph, we have an irregular bone-forming lesion along the anterior cortex of the tibia, very shaggy. There is abnormal soft tissue as well. You can see this irregular periosteal reaction on the frontal. That's beautifully picked up here. On the MR, we see that same irregular shaggy periosteal reaction. It's a T2 dark lesion, bright on fat sat, and it does enhance, but there is a little bit of marrow and cortical involvement. Uh, the other choices that I had, now Gary's osteomyelitis, we should just completely forget. It just presents with cortical thickening, but it would have marrow edema. And it's an extremely uncommon lesion anyway. But here we have an adamantinoma, which I've shown earlier as well, which is a typical, you get this bubbly appearance, so you can get a more destructive lesion involving the cortex, usually the anterior cortex, and then extending into the marrow cavity. Here, there's a little bit of expansion on the CT. And sometimes the issue with adamantinoma is more the differential with osteofibrous dysplasia rather than with surface lesions. This is a lesion that is very interesting. The saucerization of the cortex, it is T2 intermediate, but then right here on the fat sat, some edema, a little bit of irregularity, but you don't see periosteal reaction, and this is a periosteal or a surface chondroma. And I will discuss this as a quiz once in the next 3 to 6 months. So, if you remember this, you will get it right. The histopath shows characteristic osteoid with abnormal cells, and so that tells us that it's an osteosarcoma. So this becomes a periosteal osteosarcoma. It's rare. It's less than 2% of all osteosarcomas, which are anyway rarer tumors. It occurs the peaks in the second decade, and it's usually femur and tibia, usually diaphyseal. You get a cortical surface lesion with mineralization, with scalloping, saucerization, and aggressive periosteal reaction. It's actually not that difficult to make the diagnosis if all the typical features are present. So again, irregular shaggy periosteal reaction, abnormal soft tissue, restricted to the surface, T2 intermediate, all of this irregular new bone here, and that's a periosteal osteosarcoma. Another patient here, shaggy irregular periosteal reaction, the periosteum, in fact, is lifted here, and you see this abnormal lesion, which is again T2 intermediate to dark with one central necrotic core here, and this is also a periosteal osteosarcoma. As a surface osteosarcoma, we need to differentiate this from parosteal and high-grade surface. Now, parosteal we discussed in case 27, and I had multiple examples at the time. And you can see how you get a large area of new bone. Typically, the commonest site is posterior aspect of the femur. But here you have a tibial lesion. You've got a whole bunch of different lesions seen here. And the cortex is rarely involved, and you almost never get marrow involvement. High-grade surface is like any osteosarcoma, except that it occurs along the cortex of the periosteum, then invades the marrow cavity. You get a large soft tissue component. So it's got everything that an osteosarcoma would typically have in the right age group, but it's just more towards the surface. Now, it could be a little tricky if you're not used to seeing osteosarcomas, but this is such a typical high-grade surface OGS. So periosteal osteosarcoma is an uncommon subtype, but often has distinctive radiology features that could allow a pre-histopad diagnosis. So that was the case. Surface growth, the answer was periosteal OGS or osteosarcoma. Don't forget to go through the index. We now have 48 plus cases plus snippets and lectures. That's the key to my the QR code to my WhatsApp channel. For those of you like other things, I did this snippet at CT Chest Review about hip joint biopsy and CT biopsy. Talked about why speed matters at Atmos first, and on cardiac MR, discussed why CMR is superior to FDG PET for viability assessment. You know where to comment, email, subscribe, etc. And thank you so much for listening to me.